Okay, my name is Dr. Susan Adongo. I'm here with my colleague as well. We would like to give us the rules of engagement. We will give each presenter a maximum of about
5 to 7 minutes.
5 to 7 minutes, and then we'll have a time of Q&A. Okay, I would like to ask my colleague to introduce himself as well.
Good afternoon to all of us. I'm Igor Hudic, and we can start now. Please take your attention about time of presentation. 5 till 7 minutes, please.
Okay.
Thank you.
Thank you very much.
And first presenter is Marina Yakimovska-Stefanovska. She will take talk about complete androgen insensitivity syndrome in two sisters.
Good afternoon again, and thank you very much for the opportunity. I'm Marina Yakimovska-Stefanovska, coming from University of Ljubljana, University Medical Center of Ljubljana. I will present a case report of two sisters, siblings, with complete androgen insensitivity syndrome. Complete androgen insensitivity syndrome is disorder of sexual development. It affects 2 to 5 per 100,000 people who are genetically male. It is the point of this disease is mutation in the androgen receptor gene, followed by deficient response of androgens. So the person has a lot of androgens, but all cells are insensitive of them. So we find high level of testosterone and low estrogen level. As we said, they're genetically males. They have 46XY karyotype, but they have female phenotype, normal external genitalia, and well-developed breasts, without signs of genital musculization. Usually the vagina is shorter. Sometimes it can be longer, but it's usually shorter. But there is an absence of uterus and ovaries. There are a few cases, like 2 or 3, where presented in the literature where small uterus or some part of the cervix is present. We have presence of testes, usually intra-abdominal or inguinal, and slightly longer limbs, larger hands and feet. It's interesting that 1 to 2% of prepubertal girls with inguinal hernia maybe have complete androgen insensitivity syndrome. The treatment is gonadectomy, genoplasty, and estrogen replacement therapy. Why gonadectomy? Because there is malignant potential, 3.6% at age of 25, and with each age, years, the malignant potential is higher. Our case report is in gynecological clinic. There was presented a 17-year-old girl admitted to gynecologic clinic because of primary amenorrhea. That is actually the typical story of these girls. She had also 2 younger sisters, 15 years old with regular menstrual cycles, and 14 years old with primary amenorrhea also. At the age of 1, she was operated for inguinal hernia. We then checked both sisters with primary amenorrhea, and they were both phenotypically female. External genitalia and breast development appeared as normal. As feminine structures, pubic and axillary hair were absent in both sisters. The older sister had normal vagina length, while the younger has a little bit shorter, like 4 to 5 centimeters. We performed abdominal ultrasound in both, and there was absence of uterus and adnexa. There was presence of inguinal masses and some free fluid. They had high level of testosterone. We waited for the younger one to finish adequate feminization, and performed in both sisters first diagnostic laparoscopy. Here we see the pelvis, cavum douglasii, which where we found out only free abdominal fluid. On the second photo, there is we took a picture from outside while we had laparoscope inside, and on the third picture, it is shown the gonadectomy. Histopathologic results in both sisters show presence of fibrosis and Leydig cell hyperplasia, which is typical for people with complete androgen insensitivity syndrome. But in the gonad of the younger sister, we found large cell calcifying Sertoli cell tumor. That is very, very rare pathology, and there are only less than 100 reported cases. The oncology team advised only regular follow-up. The girls are coming on for regular check-ins. We are giving them estradiol replacement therapy, and they're both well. The problem here was counseling, because these girls are coming from a family that is in a bit rural place, rural village, and parents couldn't accept that from 3 daughters that were raised like daughters, at once someone explained them that they're actually genetically males. They couldn't accept that they will not have grandchildren and that their daughters are actually males. So the bigger problem for us was the counseling, psychological approach to the girls, to the patients, to explain them what is their problem, and also to the parents to understand their problem. Thank you very much.
Okay, thank you very much for having attention about the time of presentation. Any questions? Only one question, please. Okay, thank you. Yes, I'm sorry.
Yes. No, but until the age of 14, she didn't have amenorrhea. And because we had this one girl, we asked, do you have any siblings? And we checked them both. Actually, we checked in the way that we checked first testosterone in the second one, and we found out. So it was easier for the family, and it was easier for the older sister to accept that if her sister has the same thing. But it was shock for the family. Thank you.
Okay, Marina, thank you very much for your presentation.
Okay, we'll call upon the second participant, Hevra Ekin Yulusoi, to give us a presentation on development of ovarian gonadoblastoma with dysgerminoma in an adolescent with 46XX pure gonadal dysgenesis. Welcome.
Second presenter is not here, or? Okay.
Okay, we'll go to our third presenter, Dr. Mikhail Diakosavas, who will give us a presentation on a single-center 10-year experience in adolescents treated with gonadectomy for XY karyotype. Welcome.
How can I put it in presenter view?
F5.
Not this one, the one where I can
see
my notes.
Notes.
Thank you. So, is this open? Okay. Okay, great. So, good afternoon. I'm Michael Diakosavas, and I will present to you the 10-year experience of our department in female adolescents treated with gonadectomy with XY karyotype. So, at this point, I should mention and also thank the pharmaceutical company Unipharma for providing me with the opportunity of being here today, since they supported me with the registration cost of this congress. In the beginning, we should address certain facts. Most causes of DSD are recognized in the neonatal period. Later presentations include delayed or incomplete puberty, virilization, maybe primary amenorrhea, and possibly bilateral inguinal hernia. The incidence is estimated up to 6.4 per 100,000 births of female newborns. Due to the malignant potential, female patients with XY karyotypes usually require gonadectomy. The age of surgery depends on the risk of malignancy for each syndrome, but we will analyze it further down. So the aim of this study is to present the experience of our department over the past 10 years. For this retrospective review, a record of DSD patients with female sex of rearing with a Y chromosome or Y-derived sequences who were managed by the PAG department in our hospital Alexandra in Greece between 2013 and 2022 were searched to identify those who underwent gonadectomy. All surgeries were primarily performed by a single gynecologist of the PAG department, specifically Mrs. Lina Mihala, the director of the department, and the outcomes of interest were the age at diagnosis, the age at operation, the surgical management, including the surgical route, the postoperative course, and the final histology. This is the final table of our series. I know it is a little too much, but I will try to explain it and make it as simple as possible. So, our PAG department managed and treated 14 female patients with XY karyotype who underwent gonadectomy. 5 cases were diagnosed with KAIS, 6 with Swyer syndrome, 2 with XOXY Turner syndrome, and 1 case concerned an undetermined diagnosis of a partially virilized female with XY karyotype. An MRI had been performed in all patients prior to the surgery. Here you can see the MRI of a partially virilized phenotypical female with XY karyotype, which depicts the gonads located within the inguinal canal. The median age at diagnosis was 16 years old, and except for 2 girls with KAIS that had the gonadectomy at the age of 20, the remaining girls were operated within 4 months from their diagnosis. So I have a video of a laparoscopic gonadectomy. 13 girls were treated laparoscopically, whereas 1 had the abdominal bilateral inguinal gonadectomy. In the video, you can see that the laparoscopic inspection of the pelvis is carried out to determine the presence of the gonads and to inspect the pelvic organs. In some cases, when the gonads are not easily identified, the gonadal vessels are identified and followed down. The gonads are removed after determination of the course of the ureters and the fallopian tubes, if there are any. In 3 of the KAIS girls, a general surgeon assisted in the removal of the impacted testes within the inguinal canal, and a reconstructive surgery, as you can see there, of the inguinal defect was performed using a mesh. The postoperative course of all 14 patients was uneventful, and they were discharged within 2 days after the surgery. The histologic examination revealed 4 cases of gonadoblastomas and 3 of these germinomas. 5 girls had normal testes, whereas 1 had a focal Leydig cell hyperplasia and a benign Sertoli tumor. So, regarding what we can address and learn from this series, patients with specific forms of DSD harboring Y chromosomal material have an increased risk for the development of germ cell tumors. The risk depends on the diagnosis. In mixed gonadal dysgenesis, the malignancy risk can be higher than 35%, with the most common tumors being gonadoblastomas. On the other hand, in KAIS, as we know, the gonads are essentially normal testes, with an approximately 5% risk of tumor disease. Regarding the indications and timing of gonadectomy, this debate is still open. Generally, the age of surgery depends mainly on the malignant potential. However, the optimal timing of gonadectomy, based on consideration of preservation of the endogenous hormone function and fertility potential, needs also to be discussed. With KAIS, there is also no risk of virilization at puberty, so a prophylactic gonadectomy relatively late after the age of 16, in most cases, to allow the completion of secondary sexual development may be advocated. On the other hand, bilateral gonadectomy should be performed in early childhood in females with gonadal dysgenesis with Y chromosome material. Regarding the ethical considerations, efforts in healthcare reform have encouraged medical providers to shift from a paternalistic view of decision-making to one where the patient and family are engaged in the process. Physicians should wait on medical decision until a patient is old enough in most cases, if the malignancy risk is not very high, and has the autonomy to decide, especially regarding this type of surgeries which are irreversible. So to conclude, in this series of 14 girls with Y chromosome, the overall rate of gonadal tumors was around 60%. The patients with Swire had the highest tumor occurrence rate, around 80%, and had either a gonadoblastoma or a dysgerminoma, and none of the Kai's women had seminomas. However, due to the limited number of these patients, a large multi-center probable study with close follow-up is needed to support these conclusions. And the second thing we should highlight is the fact that the diagnosis of XY karyotype by itself in a female patient can be distressing. These girls should be offered the opportunity to address their concern and should be allowed and encouraged to access psychological services. Thus, the management and treatment of these women should be carried out within a specialist unit with the appropriate experience, which offering the full range of multidisciplinary medical and psychological support for children and teenagers with these complex conditions. Thank you very much. If you have any questions, I will answer, apart from those concerning my hairline.
Okay, thank you very much. You are on time.
Thank you.
Any questions? Thank you.
Yeah, sure. Yeah, no, that was interesting in our series. I think all of the girls wanted to remove them immediately. We had another case of a girl who kept their gonads after the age of 20. It's not included in this series because it concerned those with gonadectomy. But she was lost in the follow-up after the age of 25. After that point, we managed here with MRI and ultrasound. There wasn't any sign of malignancy. However, we lost the follow-up. I think she moved, but we had only just one case. Okay.
More questions?
Yeah.
Yes?
Sorry? The gonadectomy? Yeah, we used mesh. Only 3 cases where it was a defect in the inguinal canal. In most of the laparoscopic surgeries, we didn't use a mesh, and it was performed entirely by the gynecologist.
He's full of
without having to open the inguinal canal. It was completely inside the abdominal cavity. You're welcome.
Yes, yes, please.
Yes.
Okay, so thank you very much for the interesting cases.
Yeah.
My question is, those you had almost 60% of tumors while you did the operation.
Yeah, that's correct. Yeah.
So the imaging before surgery was different. You saw some signs of malignancy. Was it different?
From what we expected before the surgery.
No, my question is that you can. There are people that suggest to follow up.
Yeah.
With ultrasound, with imaging.
Yeah.
So your work is very interesting because if you saw on the ultrasound or other imaging modalities signs of a malignancy and then you find a malignancy, so it means it's not good enough because once you see it, it's already malignant.
Yeah.
So that's
Okay. Thank you very much for the question. Yeah, we performed MRI in all the patients. There were some cases where we had some indications that there might be malignancy, but we also had some of the cases of the 60% of the malignancy rate that there were no signs of malignancy. And also, if I'm not mistaken, in the bibliography, it's mentioned that a lot of cases can be missed with the MRI, especially those with microscopic malignant cancer cells. So Yeah, we had, if that answers your questions, we had a lot of, I don't remember exactly how many, but we had cases with phenotypically normal gonads in the MRI and the ultrasound, which at the histology had a tumor, a malignant tumor.
Is it okay for you? Yeah.
That's really makes it very clear that you cannot follow up with ultrasound or even MRI. It's not good enough, and you have to go
Okay,
Surgery,
so just
of course,
to add up to this, okay, I understand what you are saying, and you might be right. It's not completely what I'm saying, because I don't know exactly the standards of the MRI and the ultrasound that they might use in another country. At least in our department, and with the radiologist, and because it's a 10-year series, it's not from the last year, as things have evolved over the past 10 years, we had certain cases. In other departments, they might have a better score for diagnosing pre-surgically the malignant risk. However, I don't think it's 100%. So at the end, I tend to agree with your point.
Do we have a time? Okay, the last one.
You said 5 to 7 minutes for the presentation, not the question. It's not my fault.
Okay.
Oh, sorry, it's just such a fascinating presentation. How often were you imaging?
Before the surgery, most of these girls, almost all, they were referred to us by other departments because we are a tertiary hospital. So we had one MRI prior to the surgery, and because all of the girls wanted to remove their gonads right away, we had just a single MRI. We had the consultation afterwards, told them the risk of keeping, at least for the Kais, you mean, because for the Swire there wasn't a debate. But we had the consultation of keeping or remove the testes. All of the girls wanted to remove them, so we had just the baseline MRI.
Thank you very much.
You're welcome.
Thank you, Dr. Mikhail, for that enthusiastic presentation. So we'll proceed to Dr. Akbota Yalan to come and give us a presentation on iatrogenic abdominal wall endometriosis after Strassman's metroplasty in adolescents with congenital malformation. Welcome.
Well, good afternoon, ladies and gentlemen. I'm Akbota Yalan. I'm the last year Obgyn resident of University Medical Center from Astana, Kazakhstan. Let me thank you for the wonderful opportunity to participate in this congress with my presentation about case of iatrogenic endometriosis. The frequency of endometriosis in adolescents ranged from 25 to 73%. The true disease prevalence in general adolescent population remains unknown. A major factor of severity of endometriosis in adolescent is its association with Müllerian anomalies. What is the reason for violation of the outflow of menstrual blood? A 14-year-old teenager has found a slow-growing nodule under the surgical scar, which caused periodic pains during menstruation for 2 years. She took NSAIDs to no avail. Earlier, 2 years ago, the patient was diagnosed with uterine anomaly, Robert's uterus, which manifested itself as monthly severe pain in the lower abdomen within a year after menarche. Contrast MRI of her pelvis demonstrated an uterine septum asymmetrically separating the endometrial cavity with non-communicating hemouterus due to obstruction by the septum. This congenital malformation of the uterus was an indication for Strassman metroplasty. The operation began with a vaginal hysteroscopy, which revealed a small cavity with one uterine ostium. During the laparoscopy, there was a transvaginal enlarged uterus with an ordinary fundal outline. A Robert's uterus was confirmed, which was an indication for laparotomy and Strachman's metaplasy. The septum between two hemiuterus was excised, followed by hysteroscopy, where there was a single regular side uterus with two uterine ostiums. This also confirmed on MRI on the second day after the surgery. After 2 years, there were clinical signs of endometrial scar, abdominal scar endometriosis, confirmed by MRI, which was removed surgically without compromising the aponeurosis. Histological analysis confirms the endometriosis nodule. The postoperative course was uneventful. The patient was discharged the next day after surgery and was prescribed Dianogest contusionally for 2 years. At 6 months follow-up, the patient experienced no dysmenorrhea and pelvic pain. In conclusion, in this case, the cause of endometriosis of this skin scar is a spread of endometriosis tissue from the hematometra to the incision of the abdominal wall. Therefore, the theory of the development of endometriosis in obstructive uterine malformation has been confirmed. In an adolescent with endometriosis, surgical removal of endometriosis should be considered to eliminate the symptoms associated with endometriosis. Adolescents with endometriosis should undergo postoperative hormone therapy, as this can prevent the recurrences. Thank you for your attention. Rahmet.
Questions? Comments? Okay, thank you very much. And the next presenter is, sorry for pronouncing your wrong pronouncing, Shen Qiuxiang.
Yeah.
Is that good?
Yeah.
Could you please introduce yourself?
Okay. So Chinese name is hard to pronounce. Thank you, everyone. It's my honor to be here to share my presentation. Let me introduce myself. I'm from China. I'm a pediatric gynecology. I'm working in Children's Hospital of Zhejiang University. Today, my topic is about conservative management of cervical mullerian adenosarcoma with sarcomatous overgrowth in a 13-year-old adolescent. This is a case report and a literature review. First, let me introduce the case. This is a 13-year, 2-month-old girl who came to our hospital 10 months ago. Her chief complaint is presented with abnormal vaginal bleeding for 3 months. Because of the normal imagination and blood test, we give her a hormone therapy, but her symptoms didn't improve with initial hormone treatment, and she had increased in abnormal vaginal discharge. Subsequently, cervical mass about 17 millimeters was detected by pelvic ultrasound scan. So we can see the bigger mass here with rich blood flow. Also, the mass was confirmed by pelvic MRI, which is can be see here 2 pictures. So this girl underwent excision of the cervical mass, and the histopathology suggested that a Mullerian adenosarcoma with sarcomatous overgrowth. Here is the big mass in her vagina. After surgery, we gave her PET MRI. The lesion was confined to the cervix, and there is no distant metastasis. The histopathology suggested that a Mullerian adenosarcoma with sarcomatous overgrowth. In view of the very young age and strong demand for preserving fertility from the family, she had the second operation with the excision of cervix with clear margins. But after the surgery, she refused to have the chemotherapy. At 6 months, there's no recurrence was detected during the following up. So the final diagnosis is cervical Mullerian adenosarcoma, stage 1A, with sarcomatous overgrowth. Here is the ultrasound MRI after the surgery. After the second operation, this girl had normal menstruation. However, after surgery, 7 months later, the girl developed with yellow vaginal discharge again. Here is the MRI. Unfortunately, she have a recurrence malignant tumor. So she have the third surgery 2 months ago. Right now, she has the chemotherapy. Here is the second part about literature review. As we all know, Mullerian adenosarcoma is a rare and low-grade malignant tumor. Adenosarcoma can occur in any part of female pelvic cavity, most commonly in endometrium, which is about 71%, followed by ovary, which is about 15%. Pelvic cavity is 12%, and the cervix is rarely, which is about 2 to 10%. The cervical adenosarcoma can occur in women of all ages, which with about 1/3 of cases occurring between 10 and 15 years of age. Hysterectomy with bilateral salpingo oophorectomy can had been the standard care for it. However, young parents generally wish to retain productive functions. It has also been suggested that the patient with cervical adenosarcoma have a relatively low risk of ovarian metastasis, about 2%. So there's no enough evidence to support routine surgical removal of the ovaries. When the pure sarcomatous portion of the tumor accounts for more than 25% of the primary tumor, sarcomatous overgrowth is diagnosis. The median overall survival of patients with sarcoma overgrowth was 55 months. 2-year progression-free survival was 20%, and 5-year overall survival ranged from 50% to 60%. The 5-year overall survival rate of patients with stage 1 tumor with overgrowth of sarcoma was 63% to 86%. The last part is the summary. For this girl, her first pelvic ultrasound didn't find the mass. 3 months later, the second time pelvic ultrasound detected the large cervical tumor. So for the young girls, cervical Mullerian adenosarcoma is a challenge, especially without the expertise of experienced sonographer and histopathologist. Excision of the cervical tumor may feasible option when there is no absence of sarcomatous overgrowth, heterologous alignment, or deep cervical stromal invasion. But after surgery, all these people need close follow-up. At present, it is still necessary to continue to accumulate long-term follow-up data of such patients after fertility conservation surgery, especially in terms of planning outcomes, in order to provide basis of patients to choose better treatment plans. So for this patient with low-grade early disease who wish to, who wish to preserve fertility associated with high-risk factors, what should we do? Maybe ovarian preservation surgery can be performed with close follow-up after surgery. Here's the reference. Thank you.
Okay, discussion, 1 minute, 2 minutes.
She had the third operation 2 months ago, and right now she have chemotherapy in the hospital. She's still alive, but yeah, no distance. Right. Follow up every 3 months. Yeah. By MRI or ultrasound. Yeah. Okay.
Did the follow-up surgery involve cervical reconstruction at all? What? Did the you mentioned she had then came back for follow-up for another surgery?
Yeah.
Did that involve cervical reconstruction at all, or no, due to fertility concerns?
Yeah, because she go to the other hospital, so we don't have the other information.
Okay.
Yeah.
Do you find any risk factor that caused her to have this adenosine disease? Any risk factor that you can find from this patient?
Any point?
Risk factor. Any family members who has cancer in the family, or she has already?
No history.
Thank you.
什么造成呢？他没有拿到什么疫苗啊，还是什么造成这样的问题？有找到？
Because it's not have no relationship with HPV. Maybe it happened by casual. So we don't know why it happened for this young girl.
Thank you. And next presenter is Marian Stojowski. Should be. Okay.
Oh, okay. So the next presenter is Dr. Nick Sumaya, who's going to give us a presentation on vaginal double crossplasty step by step. Welcome.
Supposed to be surprised for everyone. All right, thank you, Mrs. Chairperson, and good afternoon, everyone. Vaginal double crossplasty is a surgical technique to release, not only to release the obstruction caused by the accumulating hematocolpus in the presence of transverse vaginal septum, but it is also a procedure that can maintain the patency of vaginal canal following a corrective vaginal surgery. So my name is Nick Sumaya. I am a PhD fellow under Professor Ani Amalia from Malaysia. And today I will share with you all the step-by-step technique in performing vaginal double crossplasty. And the aim of this video presentation is to guide everyone on how to do the procedure in a proper way. And the aim is to, with minimal intraoperative complications such as bleeding and excessive tissue injury, as well as to prevent long-term effects such as vaginal shortening or vaginal restenosis. So, as I am the last presenter for this session, I will not make this session longer. So I think let the video speak itself. Can we start from the beginning? All right, and we turn off the light. Enjoy the video and the music. Thank you. All right, thank you everyone for watching the video. And I think that's all from me. Any questions? Yes.
How many cases do you have with this?
Sorry?
How many cases with this cross-cluster? Only one or
Oh, we have about 10 to 15 cases already in our center, but this is the most beautiful picture that we can capture for the whole surgery. Otherwise, we have some, this is an example of low transvaginal septum, and we have difficulties in mid as well as the higher level of the transvaginal septum. Everyone knows about this, right?
I'm from Bulgaria. We have 4 cases.
All right.
It's great results.
All right, okay. So I hope, yes.
Yeah, thank you for the nice presentation. My question is, how long is the follow-up for those girls? And especially, I would like to know if they have some stenosis later on in their life. Because you said they are making dilation, but as we know, most of the adolescents, in the age of adolescence, they usually stop everything. The compliance goes down. So the question is if it becomes like a structural stenosis. We have been, by the way, described and published another technique for transvaginal septum, which that don't need any dilation.
Oh, I see. May I know what's the name of the technique? So that
Interesting, you know, it's always nice to learn something new. So
yeah, I know. This is the basic steps of vaginal double crossplasty, and we are very fortunate because the mother of this girl is a medical staff. She is a staff nurse in ONG. So she trained her daughter herself to dilate the vagina. But we do encounter few of our patients who has vaginal restenosis, and we had to repeat the surgery with using a stand, which later will be presented by my colleague the next day for the oral presentation. It will be surprise as well from Malaysia.
Okay, we have to move on. Thank you very
All right,
much.
thank you so much.
We have okay, but okay. Ask one more question, yeah, but short, please.
How can we differentiate human atresia and vaginal?
Imperforate hymen, right? So before this, we also encountered imperforate hymen. The layer will be bluish in color, very distended, and it has only one mucosal layer because it is originated from the urogenital sinus. However, in transvaginal septum, it is the fusion of the upper part from the mullerian as well as the lower part from the urogenital sinus. So it has 2 layers which can be separated in the fibroareolar tissue. Okay, that's all.
Okay. Could you please put the second možete staviti drugu prezentaciju, molim? Ja, zato što je okay, that's good. Dobro je. Okay, the last presenter for this session is Hevra Ekin Ulosoy. Is that good? Development of ovarian gonadoblastoma with dysgerminoma in adolescents with 46X pure gonadal dysgenesis.
I am Dr. Heva Kinsoy. I am from the Istanbul Medical Faculty and I am 50-year medical resident of Israel. I am going to talk about development of ovarian gonadoblastoma with dysgerminoma in an adolescent with 46XS pure gonadal dysgenesis. And I have no conflict of interest to declare. XX gonadal dysgenesis is typically presented with absence of breast development and primary amenorrhea due to absence of hormonal production from dysgenetic hormones during adolescence. Although most of the cases with gonadal dysgenesis have a chromosomal abnormality, approximately 1/4 of the patients have normal XX karyotype. Gonadoblastoma is a rare gonadal tumor, almost always arising from a dysgenetic gonad with Y chromosome. But there are some case reports about XX karyotype and presenting with a large magnetic illness. In this case, we describe a 17-year-old girl with XX gonadal dysgenesis who developed bilateral gonadoblastoma with focal dysgerminoma. Our patient presented with primary amenorrhea and progressively increased excessive hair growth. At age 14, she started having some breast and pubic hair development. And there was no any history of hormone replacement therapy, and her past medical and surgical history were unremarkable. In our physical examination, she had tenor stage 4 breast and stage 5 pubic hair development. She also had evidence of virilization with significant degree of hirsutism and mild clitoromyopathy, and her external genitalia was normal female external genitalia. In laboratory results, her gonadal
Thank you. Questions? Okay, thank you very much.